thank everyone for joining us today. I want to start with a few housekeeping items. Please keep your microphones and your cameras off the entire webinar. So if either your microphone or your camera are on now, please turn them off. And if you have questions, please write them in the chat box and Beth will answer them at the end of the webinar. We're thrilled today to have Beth, who is a F.E.A.S.T advisor, with us to speak about supporting your loved one struggling with bulimia nervosa. Beth entered the eating disorder field in 1983 after graduating from Boston College with her master's degree in social work. She began her career as a group leader for an organization called Anorexia Bulimia Care. Beth began a private practice specializing in eating disorders in 1987. She was the executive director of the multi-service eating disorder organization, MEDA, located in Newton, Massachusetts for 17 years and left there 3 years ago to pursue a full-time practice. She specializes in treating adolescents and their families and is trained in many treatment modalities. Beth has consulted to the state hospital system and supervises clinicians and nutritionists in the field. Beth recovered from an eating disorder that she suffered with throughout her high school and college years, and we are pleased to have her present at our webinar today. Beth, thank you.
Thank you, Judy. I'm so excited to be here, and I am hoping at the end of all this, people will be able to ask questions and we'll be able to have a conversation. So I'm going to get started, and I am going to, we're going to go through the different aspects of treating bulimia nervosa. We're going to talk a little bit about why people might be struggling, various treatment options, and I'm going to give some statistics, okay? And bear with me if I'm looking down a little bit because I want to make sure that I cover all my notes. I really wanted to just have a conversation today about bulimia nervosa, okay? So bulimia is obsessive and irrational thoughts about body, food, and exercise. People do binge eat, any and all foods. Sometimes it's planned and sometimes it's not. And again, this is my definition. Compensation can be fasting, vomiting, excessive exercise. Some of the things people don't know is it can also be laxative or diuretic abuse or the use of slimming teas. I really wanted to talk about this topic because I struggled, as Judy said, throughout my adolescence and adulthood with bulimia. And I also believe that many, many people can recover. At the time that I struggled, there was no treatment. And so to be honest with you, I had to figure out my recovery pretty much on my own until I graduated college. And then I was able to join a group and start some therapy, but the services were very limited in my experience. And so I'm hoping that your experience being involved with F.E.A.S.T will be very, very different. So the thing that is really frustrating, I chose this topic and then I started looking into the statistics, and I'm on a lot of national listservs, and I wrote some questions to my colleagues. And what we come up with, to be honest with you, is there's way more research on anorexia nervosa than there is on binge eating disorder and bulimia. So I started looking and I saw all these studies like lifetime weight characteristics of patients with severe anorexia, or short-term outcome of adolescents with anorexia nervosa. And there's very little that is written about bulimia. I do have some books that I'm happy to put in the chat on eating disorders or bulimia nervosa, but there's not a ton, as much as I would expect, that's been written. So why does bulimia come into someone's life? I hope all of you that have been involved in F.E.A.S.T know that genetics is a factor. Many, many people have a predisposition to impulsivity. You might have a predisposition to binging, but the thing we need to be careful about is that the binging is not caused by ongoing restriction. And obviously having negative body image, poor self-esteem, and so much more. For me personally, and I'm gonna put in a little bit of my own experience, I grew up in an all-female environment and everybody around me hated their bodies. So that was very kind of normative in my experience. And so at a very early age, I think I just started hating the body that I was meant to live in. I am going to give you some statistics, which are a combination of ANAD, Eating Disorder Hope, and MEDA. Those are all acronyms for different organizations that I looked into. And so some of them, you know, take this with a grain of salt, okay? But about 4% of the female population in the US will experience bulimia. About 43 of those with bulimia receive treatment. There is about, and again, we're never sure about these statistics, but about 3.9% of those with bulimia may die from the disorder or will die from the disorder. 78% of those with bulimia experience have daily life impairment, and about 43.9% experience severe impairment. And again, I will let you know that in my experience during my high school and college, I would say that I was in the category of severe impairment. And yeah, again, if you have any questions about that, but my daily functioning was driven by my eating disorder. Gay and bisexual boys are significantly more likely to fast, vomit, or take laxatives or diet pills to control their weight. And about 1 in 10 clients with bulimia will receive treatment. The average age of onset is 18, although again, I think you know that I see a lot of teenagers, and I have a lot of teenagers that struggle with bulimia. And nearly half of all the clients with bulimia have a comorbid mood disorder, or more than half have a comorbid anxiety disorder. And that's very important. 11% of people with bulimia also have obsessive compulsive disorder called OCD, and 28% might have a personality disorder. The other thing that I think is very important, and this is true with a lot of the people I see, is that many people that struggle also have an addictive disorder, such as substance abuse disorder or binge spending or gambling. All right, so those are some statistics to kind of just think about. And now what I'm going to do, I want to talk about treatment options available for your loved one. The thing I think, and again, this is a little frustrating for me because I think that's a lot, when you look into treatment for bulimia nervosa, a lot of it is similar to BED. And again, not a lot of, as many studies have been done, which is really aggravating. And I think that the research world really has to work harder at getting more information. I'm sure a lot of you, if you've been involved with F.E.A.S.T, have heard about Locke and Lagrange's work, and they wrote a book specifically for FBT, family-based treatment for bulimia. And what I am going to do is tell you some of the things that I think work from the book and some of the things that I think are not as effective. And again, this is my professional opinion. When Locke and Lagrange are talking about FBT for bulimia nervosa, they're talking about the under 19. I have actually done a lot of work with families with adult children with both anorexia and bulimia, and that has been effective, done FBT. Because I've been doing this so long, we were kind of doing FBT before people knew it was FBT. So, you know, I think a lot of us who have been in the field for 20 to 30, 40 years were trying to figure this out many, many years ago, how to support our loved ones. So Locke and Lagrange talk about what I would call traditional FBT, but they add a tracking page for you for your loved one to be tracking their binge purge episodes, which can be helpful. And that's really one of the differences with the bulimia work they've done and between the anorexia. I think one of the things I love about Locke and Lagrange, if you haven't read them, is they really help you separate the illness from your loved one, and that's really helpful. I think one of the things I don't always agree with that they talk about is they kind of make the assumption that most people with bulimia nervosa are at what they call like an average range or a set point. And that has not been my experience. That was not my experience with me personally, but it also has not been my experience with other people. I think the weight range varies. And so I have some concerns about that being promoted, because I never want our loved ones to think that that there's a certain weight range that you would stay in when you're struggling with bulimia nervosa. So again, bear with me because there are a couple of things that I don't totally agree with. The other thing that Locke and Lagrange talk about, and again, that I take a little concerned about, is that the therapist that is doing the work is trained to basically tell the patient that they won't gain much weight. And again, I don't know any of you that know about health at any size, or this belief that we're not sure where our bodies are going to land once they're recovered. And so I think that it's short-sighted to be making any promises about anybody staying. And I understand anybody staying within a certain range. I understand that we want to kind of help that person calm their parts down, their anxiety, but we don't know. And again, it depends on what the struggle is with bulimia, how many times people are having behaviors every day, and all of that. All right. So what I say to my patients is, and I go before I talk about my patients, I use the word patients and clients, so just bear with me, I'll go back and forth. What I say to people is I suspect that things will balance out if you are eating regularly, okay? But I never make promises about where your weight will be. And again, that's just because I think that we really don't know what bodies do. And your body has been through a lot. If you've been binging, purging on a daily, sometimes multiple times a day, we have no idea what your body's gonna, how it's gonna react to eating food on a regular basis. All right, so I'm moving along at a very quick pace, so I know that there will be a lot of questions, and I'm gonna make sure I leave enough time for questions. So some treatment approaches. So Locke and Lagrange is one, and I would really encourage you to read their book. One of the things that we do is we're always looking at the triggers for the binge behavior. The other thing is, as a loved one, and one of the questions that came in even before this presentation is about how you support an adult that's coming back into the home. And a lot of the strategies I'm going to talk about are very similar for your adolescent as there are for your adults, okay? And so for your adolescents, you always want to be curious and help them understand what their triggers are. And I know I'm not going to have time to answer all your questions. I'm so glad the questions are coming through, but I'm going to try not to look at them until after the presentation, and then I'll try to get to all of them. You know, for some people, they do say, I don't know the trigger. Usually there's something that's been building, but sometimes there's a habitual part of bulimia nervosa too. So you want to look at alternatives, and there are a gazillion alternatives to binging and to purging. And that's up to you and your loved one's therapist to come up with. It could be anything from using gadgets, you know, fidget toys, to taking a walk if that's healthy for them, to you know, going and getting a cup of tea. There are so many alternatives, but that person has to be willing to try some of the alternatives. So what you're trying to do is help your loved one figure out ways to avoid binging and then purging. You're always, always trying to examine the behavior and the negative consequences. So there may or may not be an activating event that may be causing the binge purge, but a lot of, at least my teenagers are like, I have no idea. I don't know what caused it. I'm like, okay, but we will try to figure that out. Regardless of whether they know it or not, you're talking about coping strategies and how are you coping with or without the eating disorder? Because remember, all the coping strategies that your loved one is going to figure out are going to help them around the eating disorder, but just around life. So the other thing that I always do when I'm doing an assessment on anybody, adolescent or adult, I just ask them what their thoughts on why the eating disorder came into their life. And just getting them thinking about what is it that brought this on. And again, always understanding that genetics can be a huge part of it, but sometimes there are other things that people are curious about and wonder about. Some people say, I've had low self-esteem, I'm a perfectionist, I've always had thoughts about my appearance, I'm on social media too much. So you're really trying to help them figure it out. All right. So the big question is, how do you actually help your loved one? And again, whether you have a loved one that's a teenager or a young adult or an older adult, my way of trying to help parents is to have them be curious about what your loved one thinks will be helpful to them. Now, they may or may not be able to identify that, but I use the word curiosity a lot because I think it's very important for your loved one to think like that. And the reason I use the word curiosity is so that we can decrease the judgmental parts. All right. And that's very, very important. Now, I have been treating families with a loved one that have struggled for my entire life. And the best thing I think parents can do if their loved one allows it is you are the best distraction technique around. And I almost hands down, whenever I'm working with a family and I say, how can your family, how can your grandparents, how can your parents, how can your siblings help you? It's usually around distraction. They can take a walk with me. They can watch a TV show. They can do a puzzle with me. They can help me learn how to knit. It goes on and on and on. So this is now you can't be there all the time. And obviously your loved one needs to learn how to distract themselves. But at the beginning, it is so critical. And so your role is so important if you have that flexibility in your life. The other thing, and this is not about actually, well, it is about how to help your loved one. I want to just let you know, and this is true for all eating disorders, but I think it's really true for bulimia nervosa. The level of shame that people usually feel is unbelievable. So you want to understand that about your loved one and know that shame may be a huge part of it. Even people I've worked with and this is the culture we live in, that still anorexia nervosa for some people and starvation still feels like it is, more in control than bulimia, which feels so out of control. Okay. In general, people would never want you to see them vomiting. They would get disgusted by it. I'm saying in general, that's not true for everybody. And that it's a very shameful act to be caught binging or purging. And so it is a little different than anorexia in that way. And again, remember that, and again, this when I say things, I'm generalizing, so it's not true for everyone. So just keep that in mind the rest of the presentation. But I still do believe that sometimes anorexia gets more accolades in the world. If you have a college student who's losing weight or an adolescent who's losing weight and people are like, oh my God, whereas bulimia is not people do not get accolades for it. And most people who are giving accolades about anorexia don't know the person who's struggling with anorexia. Another thing that is critical is understanding that binging and purging is self-soothing. This is really important because it is so, people consider it like, they're like, ugh, you know, I always say to parents, don't have that face when your kid is talking about how they purge, or, you know, if you can avoid it, because it feels so shameful, as we said, but also it does serve a purpose. It's a way of numbing our emotions. And for some people, which is not really true, but some people actually believe it's a way to control their weight. And eating food can be comforting. The binge part of it and the purge part can be very comforting. And sometimes people binge and purge to procrastinate. I know for myself, when I was struggling, I would be overwhelmed with my schoolwork, and I would then have an episode. And again, did I know at that time as a teenager that that was a precipitator? No. I can look back now and look at what was going on in my life and understand it better. The other thing is it becomes habitual. I think that is really, really important to understand too, that people are like, you know, can you stop? Well, your body almost gets accustomed to it, your body and brain, and it also becomes habit. It's how you eat for many people, not everybody. And then the other thing, which I'm sure all of you know, but it distracts you from any emotion you're feeling. If all I need to worry about is how I'm going to binge and purge that day, then I don't really think as much. I don't have as much anxiety about the test I'm going to take. I don't have as much anxiety about my relational issues. All of that kind of goes away, and not totally, and it helps people manage stress. So that's a little bit about kind of things I think you need to know. All right, so now I'm going to go into some more. I think these things are also additional things that would be helpful for you to know. And it's, again, not true for everyone. But I think that lying, and I wish we had a better word than lying, is a very big part of struggling with any eating disorder, but particularly with bulimia nervosa. In my adolescence and adulthood, I don't even think I knew when I was lying anymore because I lied so much. And that becomes, again, habitual because you don't want anybody knowing when you've been binging and purging for most people. And so lying on a daily minute-to-minute basis became a part of my life, and it becomes a part of my kids' lives that I treat. And so I think the thing as a parent, I say to my families is, don't put your child or your loved one in a position where they feel like they need to lie. Like, I would not be asking directed questions, because you do need to know, obviously, about the health and safety of your loved one. But to say something like, you know, did you binge and purge today? And they're, you know, what are they going to say? It's hard, because if they're so shamed by it, they don't feel like they can be honest with you. So you really want to think about that. Okay. And I always work, you know, I'm obviously recommending for some people that has a loved one struggling with bulimia. I think the family work can be so important to talk about the communication. So, you know, a lot of people hide when they're buying binge foods. I know for many of my clients, they're like, you know, they're going to the supermarket and they're like, oh, I'm having a big party at my house. And again, you even lie to the cashier. Or I saw something came up, which is a great word, you know, the deception. That's true. I hate the word lying. So I've always been thinking about what else is a more positive way of saying it's a survival. People are just trying to survive. Another thing is spending. There can be a lot of spending and overspending on food. But as I said earlier, that a lot of people binge spend on a lot of stuff, on clothing, on other things, with that impulsivity part. And so that's something to notice. And then it's not uncommon for some of my clients to steal. And so that can be a factor too. And it's not always stealing food. It can be stealing money from your family members so that they can get the food, things like that. All right, we have so many questions coming in, which I'm so thrilled about. So I am going to, what I'm going to try to do, if it's okay with F.E.A.S.T, is I'm going to do a bit of a summary, and then maybe we can start answering some of the questions. And because that's really where my heart lies, is being able to talk to all of you. So bulimia nervosa is a very complicated illness. It does become habitual. And so kind of stopping that behavior is going, your loved one is going to need a tremendous amount of support. And it can be pretty terrifying to try to recover. It is a very treatable illness. I really do think that, that this is, I believe for all eating disorders that many, many people can recover. And so I really think that having a sense of hopefulness for your loved one is very important. I know that I've told all my patients throughout the time I've been working, and I've said, what helped you? What was the thing that I did that was most helpful? And they said, you believed in me when I didn't believe in myself. And a lot of times I'll hear parents say to their loved one, well, do you want to recover? And a lot of times my patients aren't sure how to answer that, because of course, most of them they'd say they want to recover, but they don't want to gain weight, or they don't want to feel the anxiety they feel, or they're terrified of the depression they'll feel if they stop having these behaviors. So it's not such a clear-cut answer. And then the other thing, of course, I'm going to support you doing is trying to find a therapist for your loved one that really gets this illness. And that's really, really so important, is that the therapist understand and have compassion. All right, so I believe in recovery. I believe that you as family members, I don't know if there are any therapists on this Zoom, but I believe that you as therapists have the most powerful, you have the most power in the relationship to help your loved one. And I actually believe that that is the most critical part. So if it's okay with F.E.A.S.T, then I can start answering some of the questions that are coming up in the chat.
Do you want to answer? Do you want to read them and answer them, or would you like me to read them to you and then you can answer them? Which do you prefer?
Why don't you read them, Judy, so you can just repeat them, and then is that okay?
Yes, sir.
And I'll try to answer them the best I can. I can't promise I can answer all, because I was seeing them kind of pop in as I came.
Well, first of all, I'd like to say that we've never had this many questions. So you're really a very engaged audience, and thank you for that. It makes it much more interesting and informative when there are all these questions. And before I start, I do want to say that Beth was very kind, and we're going to put her email address in the chat toward the end. And if we don't get to your question and you'd like to ask it, you can just email Beth directly, and she graciously agreed to answer you. So don't freak out if I don't get to your question. I'll do my best. So the first question is, what is the difference between anorexia nervosa binge purge type and bulimia nervosa, which is a question that I've always wondered about.
That's a very, okay, so that's a very tricky question. And the one thing I'm going to tell you is I would not put all stock in trying to assess it yourself. When I'm assessing anorexia with binge purge type, it's the primary is anorexia. And so we assess people by not only what their what the medical condition is, but how they're thinking. Okay. And some of the characteristics of people with anorexia, I think in general, are different than bulimia, because again, with bulimia, there can be more impulsivity. For anorexia, there's a drive for starvation. And then when I work with people that have anorexia with binge purge, then and again, this is not a medical, I'm not giving you the full diagnosis, but then my clients tend to binge purge, but it's on a pretty limited basis. Does that make sense to people? And you can't nod or anything, but, but, you know, honestly, as a therapist, I try to stay away from as much what the diagnosis is and really into what the treatment is. With anorexia, the hard thing is that that person has to renourish, and the problem is if they know how to then purge or binge, then that's, they have that other part that makes it a little harder to recover, I'm sorry to say. And if I don't answer the question as much as you want, please feel free to, again, email me.
Okay, so I'm actually going to combine two questions because I think they're interrelated. One is, does bulimia nervosa affect the brain like anorexia nervosa? And the other was a question about medication. Someone's doctor said not to give an SSRI for anorexia with purging, only for bulimia. And I think that, from my experience, the way the illness affects the brain and the medications that you use to treat it are intertwined. So I kind of wanted to put those questions together.
Thank you. And that's why I'm having you do this, Judy, rather than me. Yes, I think that the medication, so it's interesting that the psychiatrist or somebody said that, SSRI, you wouldn't use, I think it depends on how much people are metabolizing the medication, and then what their behaviors are. So that's how, if I'm working with a psychiatrist, and I don't do medication, but I work with, so many of my patients have medication, it's what the level of behaviors are and how they interact with the medication. Does that make sense to people?
I'll nod and say yes, but I don't know. If it doesn't, put it back in the chat box and I'll get
Put
to
it back in the chat box. But again, if you have anorexia and you binge purge like once a month, then that's different than if you have anorexia and you're binge purging every night, right? I mean, this is why it's so individualized. So it's a little hard to categorize it. And also when a doctor has said something, although I will say one thing, I've been doing this my entire life, and I still will go and get a consultation from another clinician, and a lot of people come to me to consult. And so if you ever get a therapist, a doctor, a psychiatrist, whatever, that you're wondering, is this the right treatment, or should I, maybe do a consultation with somebody, you could always go outside of the team and get a consultation, right? And so I think that that's something for you to know. There are, and also you have a right, you are a consumer, you have a right to ask a billion questions of your team. Unless, of course, you don't have a release for your adult patients. And then that's a little tricky. But then you can maybe, what I try to do, and again, this is going a little off kilter, but what I try to do is if I have an adult patient that is seeing, that will not give a release, I try to get that adult patient to at least give a release to the family therapist. And I do a lot of family therapist and family therapy. And so if the therapist and the family therapist have a release, at least we can talk. So that can be very helpful. So you really don't, my message today is don't give up and keep on trying different things.
Next question, can one purge without binging?
Of course. Oh, yeah. A lot of people purge without binging.
Okay.
And again, remember, binging is something that a human being describes. There are people you might not consider something a binge, but the person who ate felt like they binged. So that's, but there are many people, particularly I have a lot of people that, again, maybe their primary diagnosis is anorexia and they feel like they've binged and then they purge. But by standards, it was not really a binge.
Okay, you talked about shame, the shame that's involved with bulimia. So when you see behaviors, the question was when you see a person binging, but I also wanted to ask you reference stealing. So when you see behaviors, do you address them immediately? How do you address them? What would you recommend?
Okay, so that depends if you're seeing a family therapist or you're not. If I have a family where their kid is stealing, what I would want them to call me and brainstorm about the right time to talk about this. I never recommend anybody, and I'm a parent myself, by the way, and a grandparent. I would never recommend anybody impulsively respond to anything. Okay? Never. Because we make mistakes. I've made mistakes. So I think that the question is, what is the behavior? Is it a one-shot deal? Or, oh, have you noticed that maybe you're missing money from your wallet and you're wondering, is this happening more than I thought it was? You might want to wait and observe. Did you hear somebody purging in the bathroom once, twice, 3 times? And then what you want to do is find a time outside of the event to talk about it. And again, I'm going to tell you, although I think it needs a lot of support, that you talk about it without blaming, but with curiosity. All right. And I would assume, for example, I work with many families where they hear their children purging in the bathroom and they go and they say, we heard you purging. And the loved one is like, I wasn't. No, I wasn't. Or they say, I just got sick last night. I forgot to tell you. Oh my God, I ate something and I've been, so you really want to kind of figure it out, let things go, not press it, make sure that you're getting enough support and that you stay balanced and what I call regulated. Because it's not going to do your loved one any good to be like, but I heard you. I know you did. That's just not, it's not going to get you where you need to go. You have to be looking at the end result. The end result is that your loved one either gets treatment or knows that you are aware enough so that we have to figure out some next steps to support you. Not easy.
No, definitely.
I'm asking, I always say to my families, I say, I'm asking the impossible of you. And that's why as a therapist, I never judge my parents when they're like, I lost it last night. I'm like, of course you did. Who wouldn't?
Okay, next question. How does a family support a young adult living away at college? Do they give their child a chance to seek treatment there? Do you make a pact that if, treatment isn't successful and the condition deteriorates, then she needs to come home for the following semester? How does that work when it's a young adult who's trying to live independently?
Yeah. So I guess this is one of my biggest, I work with a ton of high school to college students. And so let me tell you the best scenario. And then there's, all the steps down. But the best is that my clients who become core students, that they agree to get treatment. And either myself or if I'm the family therapist to the individual, that somebody is in touch with the school and bridging that whole relationship and making sure it stays secure. Now, a couple of things I'm going to tell parents. We never know if our children are going to make it through college. So anybody that's had a pre-existing condition, I recommend that all families look at the college and try to get a specific tuition reimbursement insurance if your child doesn't make it through their first semester or any time during college. So you don't feel like you've had to pay for the whole first semester if they have to come home on medical leave. And it just gets you a little bit of money back. And I know that's a financial issue, but that's a lot of stress that parents feel when they're sending their child to college, not knowing if they're going to make it. And so a lot of times, like I have a kid, a young adult who's at college now. I'm the family therapist, and my job is to keep in touch with the whole team at her school. One, to make sure that she's still seeing her whole team and being in touch with the family. And 2, so it doesn't feel so intrusive, so the parents don't need to be in touch with the primary therapist all the time, which would feel really hard. Okay, so that's the ideal. And all of the kids that I see, if they have not been fully recovered, and again, bear with me, this is just my way, but if I'm working with a senior and they have not fully recovered, and that means no symptoms by their senior year, then I recommend they get treatment in college. Because there's a high risk of relapse. And I want to make sure that that transition, eating disorders come at times of transition. So I want to make sure that they're getting the treatment they need. So I'll look towards the college counseling. I'll look towards private practitioners. As I said, a lot of us are on listservs that are international, national listservs. So if I have somebody going to Georgia, I'll put a listserv, who in Georgia can see this kid? They have this insurance. So our job, I believe my job as a therapist, is to make sure that my clients are well cared for during college. And if they're not, it's either up to the team at home. If it's like, right, I'm in Massachusetts. So if it's a Massachusetts team, they'd give, oftentimes what we do is give symptom, like we write I hate the word contract, but we write a working agreement for that college student to be able to manage when they're there. And if they don't stay within those boundaries, we think about bringing them home.
Thank you. 2 questions in one. What is most important to look for in a therapist? And must a primary care and dietitian be part of the treatment plan or treatment team to be effective?
Okay. What to look for I used to do a presentation on finding the therapist that's right for you. Here's what I'm going to say. I don't care where you got your degree. I don't care if you've been to Harvard or Princeton or Yale, and those are all United States colleges, by the way. I think it's about the relational aspect and making sure that person has enough experience in the eating disorder field, whether it's 3 years, 5 years, 10 years, 20 years, and that your loved one feels like they can be honest about who they are, the behaviors they're experiencing, and they come out feeling, not judged, and that they begin trusting that person. It's different for everybody, like my personality, as you can tell, I have a very strong personality. I have a loud laugh. I use humor a lot. If you don't like humor, don't come to see me as a therapist, because I'm going to make jokes sometimes. If, everybody has a different personality. So you really want somebody that's going to fit. And I think it's really worth it to interview a couple of people. Like with my teenagers, a lot of times if a teen comes to me, I say, have you met with anybody else? And I recommend the parents have them interview 2 or 3 people. And if they choose me, then I really, in the first session, I ask whether it's an adolescent or an adult, but with adolescents, it's so important because they feel so controlled. I say to that teenager, what made you choose me? What was it about me that made you, you made this choice? So I think that's very important, finding the therapist that's right for you. And a lot of people, too many people stick to a therapist that doesn't feel right to them. And that's, use your gut. It's important. And Judy, what was the second? I'm sorry, I lost the second
whether
question.
a primary care physician and a dietitian should be part of the team.
Okay, so I won't, and I train a lot of people. I probably supervise about 10 nutritionists, clinicians in the field. And I won't see anybody that's not seeing a physician. Like, I just won't. In order for me to be an effective therapist, these are, eating disorders or life-threatening illnesses. I can't be sitting wondering and worrying about my patient. So I require everybody. Now, the doctor decides how often they need to see the patient, and I work with them. But to be honest with you, the way I run my teams, almost after every session, I often have a nutritionist, a psychiatrist, a doctor, sometimes a group therapist, individual and family. That's a lot of people. And sometimes a meal coach or a job, and we're in touch all the time. And if people are not in touch with me, they're not going to be a team I will choose to interact. Like, a lot of us that have been in the field pick people to be in our teams that we know are going to collaborate in the way we want. Now, again, that's not true in a lot of the more desolate areas, but I think that's the ideal. With a nutritionist, I think that nutritionists and therapists, I think both of us would say that we both want each other but we try to be gentle with that process. So if somebody comes to me and is really not wanting to see a nutritionist yet, then I may wait, but my hope is that they will go see a nutritionist, and I will keep on investigating that. And same with the nutritionist. I think a nutritionist who's seeing somebody with an eating disorder would say, I'd like you to start being a therapist, but you don't know, maybe they've had a really negative experience with a therapist in the past and they're very anxious about it. And they just feel like a nutritionist would help them more. So I think we try to figure that out as we go along.
Okay, thank you. There were two questions about genetics, and I'll just paraphrase. One was a dad who was concerned because his ex-wife has bulimia, and he's afraid that it will trickle down, to his daughter. And the other is a mom who, her mother was bulimic, and her daughter has bulimia, and her sister's daughter has an eating disorder. So clearly, we see that eating disorders run in families. So, I guess, my question just in the here and now is the takeaway lesson from genetics, meaning what do we have to, I guess, be aware of? What can we control? And how does genetics play a factor in bulimia?
Yeah, I think what we can control is how we manage our own relationship to food in our bodies. And that's like, besides the genetics, like genetics, we can't control. I had bad genetics, I had the genetics in my family to have an eating disorder, no question. But in my family system, it wasn't as much. My primary was around, my siblings and my mom had food and body image issues, but in my family is bipolar disorder, which also can have a genetic component. So I don't think we can control the genetics as much, but what we can control is how we talk to our loved ones about that genetics is there. And so we have to learn these skills to be able to manage the potential that we may have. We may end up having more of a predisposition to this illness, right? It's not that much difference when you have alcoholism in your family. And, I work with a kid who's both parents are alcoholics, and she's very cautious about how she manages her alcohol use as a young adult, right? And so I think that genetics is very important for our loved ones to understand and know. And then we try to build the skills around the genetics to manage any of the emotions we're having, whether it's anxiety or depression or what else comes up in our lives, and that we're not turning to food or body hatred or any of those things to manage it.
Okay, another question. Can bulimia go away on its own? Does it subside as one gets older in age, like mid-20s?
All of these are great questions. I think that there are people who have told me that they struggled with bulimia when they were younger and that it just went away. Same thing with anorexia or any of the eating disorders. I would be a little concerned that without trying to figure out what their coping mechanisms are, that they might be at risk for relapse. So I think that the idea is trying to figure out how you manage your emotions so that it doesn't end up rearing its ugly head as you get older. We don't know, we don't know that much about relapse. Is it a relapse? What was going on when you were younger and you were struggling? It's hard to know without knowing more about the situation, but absolutely, I've actually had a lot of parents say that children end up having eating disorders. Yep, I had bulimia when I was in college, and it just went away. I actually did this was before COVID. I did this presentation for families, and I cannot believe, there were 10 families in the room, and 7 of the parents said that they had struggled with eating disorders in their young adulthood. And many of them said that it had just gone away, but I didn't ask detailed questions about how. But I think that can happen. I wouldn't bank on it though.
Okay. Interesting question. What are the markers, if any, of successful therapy? We have an adult, child, and individual therapy. We don't receive any direct information from a therapist. It's hard to gauge, especially with the deceit aspect.
Oh my goodness, that is one of the hardest questions. I think the question I would have for your loved one is, do they feel like it's helpful? It's not always, the hard thing about eating disorders is you don't always see a decrease in the symptoms right away. But at some point you'd hope that after a period of time, your loved one would report, I am able to manage my symptoms better. I'm learning those skills. It depends on what that person is dealing with. So the reason I can't fully answer it is if, for example, somebody has a trauma history and they've never dealt with their trauma and they have an eating disorder, the therapist may be helping them deal with their trauma at the same time as helping them deal with their eating disorders. And sometimes that's hard to manage both of those things at the same time, right? I'd also want to know that the therapist is looking at a potential higher level of care. If your loved one is, I don't know to what, severity your loved one is struggling, but if it was a potential higher level of a need for a higher level of care, I'd want to know that person was at least talking about that. And the other thing, I'm biased, but I want to know that your loved one is seeing a physician. But that's just me, because I think that as therapists, we are not medical people. We cannot assess if somebody is medically stable. And so I think it's an assurance that that person is being monitored.
Okay, we have 8 minutes left, so I'm going to get in as many as I can. Someone asked earlier in the chat about can FBT be used to treat bulimia? So you did address that somewhat, but can you address it maybe, a little
Yes,
more?
I absolutely think it can. I think we have to be gentle as you are with anorexia. FBT is, you have to have the patience to be able to do and the support to do FBT in a loving, kind, and firm way. The FBT book that Locke and LaGrange wrote is Treating Bulimia in Adolescents, Daniel LaGrange and James Locke. And, there are a lot of good books on Laura Collins wrote a great book on when your teen has an eating disorder. I'm sorry, not Laura Collins, Laura Mulham. But Locke and LaGrange have written a book on bulimia, and I think it's worth reading. I kind of told you some of the things I loved about it and some of the things that I don't totally agree with, but I think it would be a very good book to look at for your teenager.
Okay. I want to try to get in 2 more questions. One is, I think, a really important question. What key vitals should the primary care doctor be monitoring, and how often? I mean, I guess how often is really depending on state, but, I think, those of us who have had kids with bulimia, the medical concern is huge. So,
Exactly.
what are we supposed to be looking for? How do we know when something is wrong? And what key vitals should be monitored on a regular basis?
I am not going to go through all of the kind of things to look for. Obviously, potassium level and all of that is critical for bulimia nervosa. But I think what I would recommend is you go to the NEDA website and look at the medical complications, and you should make sure that your doctor knows those things, because a lot of physicians don't know what to look for. And to be honest with you, with somebody with severe bulimia, I'd want them to be seen on a very regular basis, once every week or 2. And just as a therapist, sometimes I guide my doctors into what I feel comfortable. Okay. And, I'm the one, again, hopefully, that knows what some of the symptoms are. But if somebody's binging and purging multiple times a day, I'd want them to be seen a lot. And to be honest with you, if they're binging and purging multiple times a day, they probably need a higher level of care. But one of the things as a therapist, I just want to say that I talk about a lot is I talk to my patients about what it feels like, because I did struggle with this illness. I'm like, well, what happens when you shower? Do you get dizzy? When do you, there are certain things that your loved one is probably not telling you about how bad they feel. Because one of the things that happens when you have bulimia is you get used to feeling crappy all the time. I'm sorry to say.
That's really important for parents to know. Thank you.
Yeah, and I did. I mean, it was crazy. And so now I understand, but I'll say to my patients, and that's why having a therapist that gets it, if I hadn't had an eating disorder, I would have done enough reading to know that you get dizzy a lot, you get lightheaded, you feel crappy, you're exhausted, your stomach hurts. I mean, you're not pooping a lot, everything. Now, all of those things. So I'm sorry, I'm not going to give you a full list because I won't give you all. I can't tell you every lab to get, but there are tons of resources for that.
Okay, just in the next 2 minutes, somebody wanted to know, how do you stop night eating and restlessness when everyone in the house is sleeping?
That is a great question, which I would say that one of the things that you want to make sure is that your loved one is eating enough during the day, because night eating, a lot of people don't eat enough during the day. So that's just kind of the simple response. And then the other thing is whether at the beginning you want to try to help your loved one figure out when are the more critical times, and whether you can sit with them until they fall asleep or things like that. Because I don't know if your loved one is waking up. I had a patient who had binge eating disorder, not bulimia, but she waited until everybody went to bed, and then she would get up and go downstairs, again, because of the shame and because she wasn't getting enough food in. And then what her mother did was, they talked about it, and she would sit with her until she fell asleep. Not like that's great on a regular basis, but it helped break the habitual part of it.
Great.
And you have to make sure it's not night eating, syndrome. And there's a couple of books written about that.
Okay, great. I don't know. We have 3 minutes left, and I need a minute to close. So I'm just going to ask one more quick question. Someone said her daughter just turned 18. She had anorexia at 15 that turned into bulimia a few months ago. Her period stopped, and she wanted to know, does the brain get starved in bulimia like it gets starved in anorexia? Which I think is a really good question, because people think, oh, it's the lower weight that starves the brain, and it's not. So can you comment on that quickly?
No, again, I'm not a doctor, but the brain does get starved, and it depends. Look, at everybody's an individual, and we don't know what they've been eating and how much is getting metabolized when they do binge. And so it is absolutely a starved brain. I'm just going to share one personal thing. I don't remember my high school and college. Like, I really don't remember. And I'm open about it. My whole brain and body were such a mess that if anybody asks me anything, it's as an older woman now, I'm healthier now than I was during those years. So you really, really want to understand. I'm sorry to end with the severity, and it does starve your brain.
Oh, thank you. Thank you, Beth, so much. This has been so incredibly
informative. I am happy to be available. You will put my email in the chat. I can't promise I'll get back to all of you or any of you that have questions, and my answers are not like, I'm a social worker. I do the clinical work. I'm not a medical person. We have to stay in our lane, but I'm so happy to have been here. And so I have so much gratitude to all of you.
Thank you all very much for attending and for being so engaged. If you liked this webinar and you'd like to see us continue programming like this, please consider going to the F.E.A.S.T website and donating, because it's only through donations like this that we can keep these programs going. And I just wanted to let you all know about our next webinar. Our next webinar, which is in October, it's October 13th, medical complications in children and adolescents with feeding and eating disorders. And we're sure that one's going to be great too. So thank you again, Beth. Thank you everyone for attending, and we'll see you next month.